All right, good morning. Welcome to In the Trenches with David Cohen. Today's topic is going to be acute kidney injury. Common problem we see in the hospitalized patients. How do you define it? Normally it's a creatinine greater than 0.3 from baseline. If you look at criteria, there's something called the Rifle criteria, which is risk, injury, failure, loss of function, and then this is about a month at end stage renal disease. This is 3 months. These are the three things you go through: risk, injury, failure. And the things that determine what level you're on this is you're bumping your creatinine and you decrease urine output. Okay, so you make the distinction of patients in acute kidney injury. We used to call this acute renal failure. AKI is the term we use now. So you want to categorize it. You want to find out what the cause is. So you're going to divide this into pre-renal, renal, and post-renal. So pre-renal is a common cause. This is before the problem hits the kidneys. Somebody's very dehydrated. They're over-diuresed. They're septic. They're bleeding. Or they're in some form of shock. That's pre-renal. Post-renal, you have obstruction. And, this could be BPH, bilateral stones, cervical cancer, any type of mass, bladder cancer, lymphoma, retroperitoneal fibrosis, and other things. And then you have renal. Okay, now renal you could basically divide into 4 categories. Okay, you have the tubules, the glomeruli, the interstitium, and the vasculature. So let's go over. So when you're assessing somebody, we're going to talk about pre-renal and post-renal first. Obviously, you want a history and you want an exam. Someone examines orthostasis, poor skin turgor, dry axillary sweat, no axillary sweat, and you can look at the mouth and they appear caked. That's a patient who's dehydrated. Okay, if you can check them for orthostatic blood pressure and pulse changes. Sometimes these patients are too sick. Often these are nursing home patients or elderly patients. Okay, or they could be septic, and you're going to look for a history. Somebody's massively bleeding. Okay, we presented a case like that earlier today. Then that's a reason to be pre-renal. That's pre-renal. Now, what you're going to also do here, tests you could use, you could get a urine sodium and calculate a fractional excretion of sodium. If the urine sodium is under 10, theoretically if it's under 30, but if it's very low, usually it's pre-renal, not 100%, but the body's responding, they're resorbing sodium proximally. And you can calculate a fractional excretion of sodium, that'll be greater than 1%. Now the bugaboo here is if someone's on diuretics, and they're over-diuresed or whatever, and then you can't use the urine sodium or the FeNAD. You need to calculate a fractional excretion of urea. But that's just something that you could do. You could also look at the specific gravity, and if the specific gravity is elevated, if it's high, it tells you the urine is concentrated, and the patient is most likely dehydrated. Somebody's in kidney failure, they cannot concentrate the urine, it will not be that high. And the other thing, urinalysis, and really somebody with AKI, you need to look at the urinalysis. The UA is going to be bland. You're not going to see anything there. Now, post-renal, it's very important to get a renal ultrasound and evaluation. Okay, number one, okay, you want to see how many kidneys they have. Someone could have one kidney. They might not know it. You could live with one kidney. Okay, number two, you want to rule out a hydronephrosis. Now, with acute kidney injury, theoretically, you need bilateral hydronephrosis, but that could occur, and you want to evaluate for that. Okay, and the other thing, you're going to look at the size and echogenicity of the kidneys. So, if the kidneys are small and they've increased echogenicity, the patient has chronic kidney disease. I mean, you might not know their baseline. Maybe this isn't acute, or maybe it's acute on chronic. Okay, if they have normal size, and really the size, the rule of thumb is the size of kidneys should be 2 times your lumbar, your L2 vertebra. Multiply it that times 2. Normally, a kidney size somewhere 10 to 12 centimeters. A petite person is going to have a little smaller size of muscular. Bigger person may have a little larger. The echogenicity, if the echogenicity of the kidneys approaches that of the liver, that's what's known as medical renal. We used to call it medical renal disease. Now they call it medical renal disease, and that's chronic kidney disease. So the renal ultrasound is important in evaluating these people. The other thing that can cause post-renal is just urinary retention. And you put a Foley in the patient, and that could, they can start urinating and the renal function improves. So let's talk about, now most of these patients have renal causes. So how are you going to approach this? First of all, it's either ATN or non-ATN. So if it's ATN, okay, here you're going to see muddy pigmented cast. That's the hallmark. Now ATN has two causes, ischemic and nephrotoxic. So ischemic, if somebody has prolonged pre-renal injury, they could shut down their kidneys, and they could go from pre-renal to ATN, and that's all the causes we talked about. What are the nephrotoxins? Somebody could have rhabdomyolysis, myoglobin, massive hemolysis, hemoglobin, tumor lysis syndrome, uric acid precipitating the kidneys, phosphate nephropathy with old colonoscopy preps. Contrast-induced nephropathy. Now, this is becoming controversial whether it actually does this or not, but I'm going to put this put this in here. Platinum-based chemotherapy, aminoglycosides, IVA cyclovir could precipitate. But there's some ethylene glycol. All right, you're not going to see that a lot, but you have to think about that. There's some type of toxin. There's some type of toxin doing this. This is ATN, okay? Now, what about glomerulonephritis? This is tricky, but you have to think about this because this is a whole other pathway. So if you see red cells, and especially red blood cell casts in the urine, you have to think of acute glomerulonephritis and possibly rapidly progressive GN. And with that, you're going to break this into three causes: immune complex, anti-GBM, and pausing immune. Okay, so the immune complexes, and here you're going to get complement levels. You can see this with post-strep GN, other infections like endocarditis or shunt nephritis, which is something we obviously don't see a lot. You can see it as a form of lupus, cryoglobulinemia, membranoproliferative glomerulonephritis. You can see this with the IgA nephropathy, which the complement levels here will be normal. But these are things you think of here. Anti-GBM, if it involves the lungs, it's good pastures. This is a granular, this is a linear appearance. This, I tell you, I've never seen a case of this in my career. And paucity immune would be the ANCA-related diseases, especially GPA and MPA, where you're not going to see that much in the biopsy. You know, and here you have pulmonary renal syndromes and stuff going on in the lungs usually. And with GPA, you have upper airway involvement, and this could involve other areas. So the way, if you see this, you're going to get complement levels, and you could risk stratify. You could kind of figure out what's going on based on whether the C3, C4, or both are low. You may get an ANCA, and you may get any GBM antibody, and if it's positive, let me know. Okay, I've never seen that, but that's how you kind of approach that. And these individual diseases have their own treatment. Acute allergic interstitial nephritis is something that you could see. And the classic triad with that is fever, rash, and eosinophilia. You usually do not see that, okay, but you can see urine eos. And if you really suspect that, you could actually get a nuclear scan and the kidneys light up. Originally reported with antibiotics like penicillin and sulfa. The drugs that do this the most are probably the PPIs. And if you have somebody on a PPI, you can just put them on it, and they develop this, you have to think about that. They've also reported this with thiazides, with non-steroidals, and with other drugs. And then vascular, you know, the larger vessels would be bilateral renal artery stenosis, bilateral renal vein thrombosis, very unusual. But here you have to think of the thrombotic microangiopathies, TTP, and hemolytic uremic syndrome. And these things, I mean, we have a couple cases a year of these that comes in. And here with these, you're going to see a microangiopathic hemolytic anemia with schistocytes of the smear. Okay, thrombin and low platelets, and AKI, and, you know, with TTP, you can have neuro symptoms or fever. You know, TTP is usually, you get an Adam TS13, hemolytic uremic syndrome. You know, this is often post-diarrhea if there's a prodrome, and then there's a congenital HUS, which is due to abnormality in the alternative complement pathway. I think that's far beyond what I want to discuss here. You know, so basically, you know, let's just debrief and just go over this. So you have somebody come in and they have AKI. Obviously, it would be helpful to know what their baseline renal function is. Okay, you know, you're going to do a history physical, obviously their medicines or potential toxins, evaluate them for pre-renal azotemia, get a urine sodium, look at their specific gravity, possibly calculate a FIDE, get a renal ultrasound, and if you can, look at the urinalysis. Okay, that'll give you clues. If there's a suspicion, if you see muddy casts, you know, make sure the patient doesn't have rhabdo, especially somebody lying around for a while. You know, get a history of the medicines they're on. And the other big thing, and I'm sorry, this is my mistake, that causes ATN toxins, non-steroidals thing to it. I'm glad I picked this up before this is over. Very, very important by inhibiting renal prostaglandins. You know, if you don't know what's going on, get urines for EOs. And if there are medicines that could potentially do that, that's your answer. Usually the vascular, TTP, and cousins, these people are going to be sick. There are going to be other clues of what's going on, but it could cause AKI. And with that, I'm going to stop. Thank you.